In this video, I'm going to tell you everything that you need to know about medical coding for cerumen removal. This includes the codes, code requirements, documentation tips, and a lot more. So if you're a healthcare provider that is looking to make sure that you document, bill, and are reimbursed appropriately for these services, or you're just interested in learning about medical coding, definitely stick around because I will be covering all of that in this video. Hey everyone, I'm Victoria. I'm a medical coder, auditor, educator, and content creator, and on my channel I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, highly encourage you to subscribe, hit that notification bell so that you can get alerts when I post all of these great tips, tricks, and tutorials. By the way, if you want to become a certified medical biller and coder in 6 months or less without going into student loan debt, you definitely have to take my masterclass, which is linked below. In the masterclass, I share everything I've learned in over a decade of medical billing and coding, my industry insights, how to get the right training, what certifications you're going to need to be successful in medical billing and coding, how to save time and money on training, and a whole lot more. It seriously gives you that whole roadmap of, hey, I'm someone who's interested in becoming a medical billing and coding professional, to getting that training and being job ready in as little as 6 months. So definitely check out the link in the description below for the masterclass. So what is cerumen? Cerumen is that earwax, and you'd think it would be a simple thing to code for, but astonishingly, there's still a lot of confusion that goes around how to code for cerumen. First things first, we have to make sure that the documentation supports that it is impacted cerumen. If it's just a routine cleaning of an ear, that really doesn't have medical necessity to be done by a physician. Most insurances don't reimburse for it. There actually isn't a code for like cleaning out your ear with like a Q-tip, which technically you're not supposed to do. They always say like don't put anything, smaller than your elbow into your ear. I personally am a big Q-tip girl. I love cleaning out my ears with Q-tips. Sorry, Dr. Mike. Now, for coding purposes, there is actually a CPT assistant article from October of 2013 that defines from a coding perspective what we would consider impacted cerumen. So it's on October 2013, page 14. It states there could be visual considerations. So the cerumen impairs exam of clinically significant portions of the external auditory canal, tympanic membrane, or middle ear condition. Or it could be qualitative considerations. It's extremely dry, it's hard, it's irritative, and it's causing symptoms such as pain, itching, hearing loss, etc. Or there could be inflammatory considerations. It's associated with foul odor, infection, or dermatitis. Or quantitative considerations. There's obstructive, copious cerumen that cannot be removed without magnification and multiple instruments requiring physician skill. Now, the diagnosis codes are going to be from the H61.2 section, and that's going to depend on, is it not specified in the documentation which ear it was, which side? Was it right, was it left, or was it bilateral? And again, that has to state in that documentation impacted in order to use those impacted cerumen codes. Now, while there are no excludes notes specific to these different codes, it kind of stands to reason that, you're not going to code for the associated signs and symptoms of that impacted cerumen, or you're not going to code the patient as having permanent hearing loss when really the cause of that temporary hearing loss was just because their ear was impacted with cerumen. If we have cerumen and there's no documentation of it being impacted, not only can we not use those diagnosis codes, but we can't use the CPT codes as well. So any services related to that cerumen, the non-impacted cerumen, or not documented as impacted cerumen, is going to get encompassed into that E&M service potentially for that day. So a lot of them are probably going to be like office visits. So if the provider doesn't document that it was impacted, we can't get an addenda saying, oh yeah, it was impacted, and definitely use these codes. It all gets encompassed into that evaluation and management service for that day. And that is in the guidelines surrounding the codes for removal of impacted cerumen. It says there that if it is not impacted, you use the appropriate E&M code. We have 69209, which is when we are doing lavage. We're just doing irrigation. Oftentimes they'll kind of tilt the patient's head to the side and they'll flush it out with water, and there's usually like a cup there for any of the cerumen that falls out to be caught in the cup with all the extra water. And then 69210 is when the provider documents that they used some sort of instrumentation. So they used a curette or a cerumen spoon or a forceps, some sort of documented instrumentation was used to remove that impacted cerumen. Another one to consider is GO268. This isn't usually done in your primary care settings like other cerumen removals, but that code is for Medicare patients if they're having an audiological exam and there's such impacted cerumen they can't do it, so they have to remove that impacted cerumen in order to do the audiological exam, you can bill it for Medicare patients with that G code. Now, if the patient's coming in and it's just like a routine hearing test and they're like, oh, let's clean out your ear before, we do the hearing test, insurances don't cover that. Now, only one of those CPT codes, the lavage or instrumentation, can be billed on the same date of service for the same ear. So let's say the provider attempts to do a lavage, they can't get it all out, and they go, you know what, let's go on and do the instrumentation. We're going to bill just for the instrumentation because we can't bill both of them for that same ear on the same day. Both the codes are unilateral, so think about your RT and LT modifiers if you're doing it on the right ear, if you're doing it on the left ear, 50 if you're doing it bilaterally. Although I will say that Medicare, regardless if you do it bilaterally, even if you have split it onto 2 lines, whatever which way from Sunday you bill it, they're not going to reimburse it at that 150%. They only will ever reimburse for that one quantity of the cerumen removal. Although now that I said that and put that out there, I'm sure someone's going to leave a comment saying, well, I bill it this way and then Medicare pays for the unit of 2. On the topic of modifiers, we also have to consider our modifier 52 for discontinued procedure. So let's say we're doing a cerumen removal with instrumentation. The patient's having a lot of discomfort and we decide, you know what, we just have to discontinue the procedure. We'll send them home with some ear drops instead to hopefully maybe loosen up some of that impacted wax because it's so hardened and dry. We can still bill that, but with the 52 modifier to designate that it was discontinued. We did not get to complete the entirety of that procedure. Now, before we get into cerumen and office visit on the same day, our modifier 25 concerns, one of the things I get asked a lot is, what about ancillary staff? Can an RN, an LPN, a medical assistant perform a cerumen removal? Technically, Medicare states that this can be performed by ancillary or auxiliary staff and billed incident to, but you also have to consider scope of practice. So is that ancillary staff, like a medical assistant, is it within their scope of practice of that state, and are they trained clinically to do that procedure? I've worked in some practices in the past where they're like, our medical assistants, yeah, no, I don't think I want them touching patients' ears. That's too much of a liability. Now, cerumen removal and an E&M service on the same day. In order to bill for both of them, we have to meet our criteria for modifier 25. And what does modifier 25 say? It has to be a significant, separately identifiable procedure done on the same day as an evaluation and management service. So if the patient comes in and they're like, I can't hear out of this ear, and you look in it and it's impacted with cerumen, and we take all that cerumen out and they go, oh, you know what, that resolved it. We're only going to bill that procedure. There's nothing significant. There's nothing super separate to bill out a separate E&M, to warrant a separate E&M. Everything was related to that primary problem. Like, the presenting problem was resolved by that procedure. And this is supported in a CPT assistant by the AMA. It's official coding guidelines, and it's from 2016. It's 2016, volume 26, issue 1, pages 7 through 8. It states, a 69-year-old male presents with recent worsening of hearing in the left ear over a several-day period. He is found to have a cerumen impaction filling the entire external auditory canal. Physician physically removes the cerumen from the canal with instrumentation and magnification. And in that case, only the cerumen removal is billed. And for the record, because of the licensing with CPT Assistant, I cannot send you the link for that. You have to purchase it yourself. I cannot send you a copy because I don't own the rights to it. However, this is also supported by CMS, which I can link in the description. So it says that an E&M service on the same day as a removal of impacted cerumen may not be billed unless it represents and is documented to be a significant, separately identifiable service on the same day. So here's some examples that they give. So the first example is the patient has pain in their external ear. That's their only complaint, and they have that cerumen removed and it resolves that pain. We're only billing for the cerumen removal. However, if that patient has that cerumen removed and they've got otitis media, so if they've got an infection or they still can't hear out of that ear after we take out all that impacted cerumen, then we're going to warrant some additional examination, some additional questioning, some additional workup we might have to be doing. And that's when we get that separate E&M. every single procedure is going to have a built-in evaluation and management component. You're not going to do something invasive on a patient without at least examining that area, maybe some surrounding areas, ask them about their allergies or a medical history. So that's all built into the reimbursement for every single procedure, is that you're going to do some evaluation and management related to the performance of that procedure. So that's it. Those are all of my best tips for appropriately documenting, coding, and getting reimbursed for cerumen removals. If you found this video interesting and you want to get started in your journey into medical coding, definitely check out the masterclass linked in my description. If you want to know more though, just about like how to get started in medical coding, you can check out this whole playlist. I have an entire playlist of all the stuff for people who just are interested in becoming a medical coder. I will see you guys in the next video, and until then, just keep on coding on.